Welcome back to Chapter 22, the respiratory system. This is Part 2. At the end of Part 1, we discussed the fact that the lungs are not able to inflate and deflate themselves. Instead, what they do is they have to rely on the muscles that surround them, such as the diaphragm and the intercostal muscles between the rib cages, as well as a pressure difference for the lungs to go ahead and inflate and deflate. And as a result, what we see is that air will then flow in when we're inhaling, and air will then flow out as we're exhaling. So we're going to kind of pick up that discussion in Part 2, and on our first slide we see that there's a discussion about pressure and flow. And what we see happening here is when you discuss the respiratory system, you want to keep in mind two pressure points. You want to keep in mind the atmospheric pressure, which is what's happening on the outside of the body, so in your environment, in your atmosphere, and you want to keep in mind the intrapulmonary pressure. The intrapulmonary pressure, aka the pulmonary pressure, is the pressure that's inside of the lungs. And what we're going to see happening is that we need a pressure difference between these two different environments, so between the atmosphere on the outside and the pulmonary on the inside, in order for air to flow. And air will always flow from high to low pressure points. So what we see happening in addition to the pressure flow difference is that oftentimes the size of the lungs or the volume of the lungs will also help us generate different pressure points. So as you can see in the middle of the slide, it says intrapulmonary pressure and lung volume go hand in hand because the pressure is going to be inversely proportionate to the volume of the lungs. So if the volume of the lungs is high, meaning that the lungs are expanding, we see that the intrapulmonary pressure will be low. On the other hand, if the volume of the lungs are compressed and it decreases, then what we see happening is that the pressure intrapulmonary will start increasing. So it's an inverse relationship between the size of the lungs and the pressure that it's generating. Now what we're going to do is we're going to take the atmospheric pressure, we're going to take the intrapulmonary pressure, and we're going to take this concept of pressure is inversely related to volume, and we're going to take all these concepts and try to explain why we inhale and exhale air. So let's go ahead and look at our next slide. And here you will find a little makeshift diagram that I drew for you. And what you can see is on your left-hand side, we have an illustration that's going to help us explain our inspiration, our inhaling pattern. And on the right-hand side, we have the expiration or the exhaling pattern. So first things first, I know I'm not an artist, so bear with me, but the large pink structures are meant to represent your lungs, and the purple outlined around it, that's going to be your thoracic cavity, and at the bottom line of purple, that's going to be your diaphragm muscle. Now, please remind yourself that the diaphragm muscle, when it's relaxed, it's naturally a domed shape. So it will be pointing upwards, very similar to the bottom of the purple diagram in the exhaling pattern. So you can see how the bottom, the diaphragm, is popping upwards. Now, a few things to keep in mind. So, as we mentioned on the previous slide, air will flow from a high pressure point to a low pressure point. Some of you might be recalling this from when we did blood flow through the heart. So we're going to do the same concept. We're going to go from an area of high pressure to an area of low pressure. And in order to assist us with making different pressure points, we're going to take a look at the size of the lungs, because the volume of the lungs will be inversely related to the pressure that's happening inside the lungs. Okay, so first things first. If you want to inhale, hopefully everyone will agree with me that inhaling means that air has to move from the atmosphere into the lungs, right? It has to move inwards. So on my left-hand side, you're going to notice that I drew a big arrow that's going into the lungs. And in order for us to inhale, we have to go from a high pressure point to a low pressure point. So that means that my atmospheric pressure has to be high and my pulmonary pressure has to be low. And to assist me with my pulmonary pressure, you're going to notice that the lungs have expanded. When the diaphragm contracts, it falls down, And when it falls down, it expands the thoracic cavity. And as a result, what we see happening is that the lungs that were sitting right on the diaphragm, they also fall down and they expand. And as they expand, their volume increases. So on your diagram I wrote down for you, your lungs expand, the volume becomes high, which means that it's going to be inversely related to the pressure. So the pulmonary pressure is low, which then means that air will flow from high to low, from atmosphere to pulmonary, and we're inhaling. Eventually, we see that the diaphragm is going to go ahead and relax and go back to its natural state. So it's going to pop back up. So let's go ahead and look over to our right side. And what we see happening here is it says the diaphragm muscle has relaxed. It has popped back into its natural shape. And when it pops up, it basically scoots the lungs up and it allows the lungs to compress because the thoracic cage is going to get a little bit smaller. It's not as stretched out as it was before. So as the thoracic cage gets smaller, the lungs have less space. So they're going to go ahead and they're going to shrink. And as they're doing this, the volume is going to be low. When the volume is low, the pressure will be high, which means that when we're exhaling, the air is going to go from high to low, high pulmonary to low atmosphere. Notice how the arrow is now pointing outwards. A few things to remember here. Air will always go from high to low. And as the lungs expand, their volume becomes high. It generates a low pressure point. When the lungs shrivel or shrink, their volume becomes low. The pressure becomes high. To be completely honest, there are different pressure points that the lungs generate. So on this slide right here, it talks about the fact that you have something called intrapleural pressure. Intrapleural pressure is generated by the relationship between the visceral and the parietal pleura, which is that covering, that connective tissue covering that we find across our lungs that helps with the reduction of friction and compartmentalizations when it comes to disease being able to hop from one organ to the next. We also have transpulmonary pressure, and transpulmonary pressure is based on the fact that if we take our intrapleural pressure and we minus that from our intrapulmonary pressure, which is the pressure that you find inside the lungs associated with the volume of the organ, what we see happening here is that it then generates the transpulmonary pressure. Now, the reason I bring up these different pressure points is because I just want to inform you that there are different agents that will contribute to the pressure changes that we see when we inhale and when we exhale. For our class, because we are an introduction level to anatomy and physiology, we're basically just going to concentrate on the two main ones, which will be our atmospheric pressure on the outside and our pulmonary pressure on the inside of the lungs due to the volume. So on your exam, you will not come across intrapleural or transpulmonary pressure, but you will see lots of mention of pulmonary pressure or intrapulmonary pressure and atmospheric pressure. And remember that when you're going to move your air, you're always going to go from high to low. So over here on the slide, the title says inspiration, or to inhale, means that your body is responding to a low intrapulmonary pressure, and this is due to the fact that the lungs have expanded because the diaphragm has contracted and the thoracic cavity has expanded as well. And as the lungs expand, the pressure drops inside, allowing the air to flow from high atmospheric into the body, into the lungs. And usually what we see happening is that the air, as it's traveling through our nose, we discussed the fact that the nose is able to warm it and humidify it. Well, those characteristics will actually assist the lungs with inflating, allowing for more air to flow in during a regular inhale, which usually does about 500 mL of air. When it's time to exhale, what we see happening is that we have different things to consider. So on this slide, what we're doing is we're taking a look at a passive expiration or a passive exhale. So what the slide tells you is that when you're exhaling, basically what you're doing is you're just kind of resetting the body to its normal stage. So we're basically looking at the muscles such as our diaphragm and our intercostal muscles. Those muscles all had to contract to go ahead and initiate your inhalation pattern. And now what we see happening is when those muscles go ahead and return to their normal state and they relax, then the lungs will also go ahead and become compressed and return back to their shriveled up or smaller size, allowing for your exhaling pattern to develop. And this is all due to the fact that the volume of the thoracic cavity decreases, which means that your intrapulmonary pressure increases. And this all goes hand in hand with the fact that the volume of the lungs have decreased as well. Now, a passive expiration is simply the resetting of the muscles, and as the muscles are resetting, it goes ahead with the shriveling of the lungs and the increase of the pulmonary pressure on the inside. So what we see happening is that normally you have direct stimulation again from the phrenic nerve. That nerve will go ahead and stimulate the diaphragm, and the minute the diaphragm is relaxed, it will get a stimulus from the phrenic nerve, and that will cause the diaphragm to contract right away. And as it contracts, it falls down, the lungs expand, we see that our pressure point drops, and we can do our inhalation pattern. And this is a continuing cycle that we see every time we're inhaling. We need the muscles to contract, and every time we're exhaling, it's simply the result of the muscles relaxing and going back to their normal state. So if you think about it, does it take more effort to inhale or to exhale? What do you guys think? Hopefully you will agree with me that it takes more effort to inhale, because if you want to inhale, you have to go ahead and you have to activate all those different muscles for them to contract, which will then cause a change in the size of the thoracic cage and the lungs, which will then adjust your pulmonary pressure. On the other hand, when you are expiration, or when you're doing an exhale, it's simply the result of the lungs going back to their normal set because the muscles are relaxing and waiting for their next stimulus to come along. Now, what if you want to do a forced expiration? So a forced expiration basically means that we're doing an excessive exhale, a forceful exhale. So maybe we're doing a sigh, or we're screaming, or even if we're trying to sing and we're trying to hit that high note. What we see happening is if we want to forcefully expel air, we're going to have to recruit additional muscles over to the site. The more muscles you recruit within the thoracic cavity, the more of a pressure point you generate on the inside. And as you increase your pulmonary pressure on the inside, it allows the air to flow at a faster rate, expelling itself from the thoracic cavity and going into the atmosphere. We also see that there's cases where sometimes air will develop into the pleural cavity. This is called pneumothorax. So on the illustration that I've inserted for you, you can go ahead and you can see that if air ever develops within the pleural or the covering of the lungs, it will cause the lungs to lose some of its negative pressure points, and as a result, the lungs will recoil and collapse. You're going to notice that your patient starts wheezing and has severe shortness of breath, and that's because the lungs are not able to inflate and deflate as they normally would whenever you're doing your pulmonary pressure points and you're doing your inhaling and exhaling pattern as normal. A lot of the times, the treatment of pneumothorax involves the insertion of a chest tube that will allow the trapped air to escape. And as the air escapes, it allows the lungs to kind of reset and regenerate that intrapleural pressure. Many things can cause pneumothorax. We have seen it in patients that come in with a bacterial infection, a viral infection, sometimes as part of an autoimmune disease. And there's also been cases where patients that have developed cancer cells that as a result will cause the air to gather within the cavity of the pleural. The next thing that I want to discuss with you is resistance to airflow. Now, resistance is anything that's going to slow down airflow. And it turns out that when you take a look at your breathing pattern, there's going to be three things that are going to contribute to resistance. The first one is going to be pulmonary compliance. The second one is going to be the diameter of the bronchioles. And then the third one is going to be the alveolar surface tension, which I'll show you on the next slide. Let's go ahead and take a look at pulmonary compliance. So this is going to be the first characteristics that can contribute to the resistance to airflow, which means that it has the potential to slow down how fast air either travels into the body or outside the body. So either you're inhaling or you're exhaling pattern. Now, pulmonary compliance basically means how willing are the lungs to stretch and recoil back to their normal shape. So how flexible, how distensible are the lungs? So for instance, a patient who is relatively healthy, we see that the lungs are very flexible, they have some nice elastic recoil, so they tend to have a very high pulmonary compliance. The lungs are cooperating with you, which means that your resistance tends to be a little bit low, making air easy to flow in and out. On the other hand, if you have a patient who, for instance, has black lung disease, or maybe a patient who has had lung cancer and now has maybe scar tissue or fibrotic tissue within the lungs, what we see happening is that the pulmonary compliance will be reduced. The lungs are not as willing to inflate and deflate. And as a result of a decrease in pulmonary compliance, it will increase the resistance, slowing down the airflow, making it harder for your patient to have adequate oxygen and carbon dioxide exchange. So pulmonary compliance takes a look at how willing the lungs are to stretch and recoil, how good are they at inflating and deflating. The second one is going to be the primary control over resistance, which is going to be the bronchial diameter. So what are the diameter of the bronchioles? So think back to your respiratory tree or your bronchial tree in part 1, where we talked about the fact that as air flows into the trachea, it then gets subdivided into the primary, secondary, and tertiary bronchioles as it enters into the lungs. Now, the diameter of the bronchioles can either decrease or increase, and if it's decreasing, we call it bronchial constriction. Bronchial constriction means that the lumen, the opening of the bronchioles, is reduced. Therefore, there's an increased amount of resistance, which will automatically slow down your airflow. This is what we see when patients are, for instance, suffering from an asthma attack. Anytime that there's cold air, it tends to cause a reflex that will cause bronchial constriction. So that's why some patients, especially patients with COPD, have a really hard time breathing when the weather gets a little bit colder. We also see that histamine release can cause bronchial constriction. Histamine is usually associated with an alert system for your immune cells, but in case it's released in the sense of an allergy, it can cause you to develop asthmatic symptoms. Bronchial dilation is when we increase the diameter of the bronchioles and we increase the lumen. And as we increase that opening, it makes it easier for air to flow at a faster rate. So we therefore decrease our resistance and we increase our airflow. We usually see this, as you can see from the example, whenever our sympathetic nervous system is activated and our body is filled with epinephrine. So if you're doing things like exercising, it'll be a fantastic way to stimulate bronchial dilation. The third thing that will contribute to pulmonary resistance is going to be alveolar surface tension. So as you might recall, your alveoli are your little air sacs. These are the functioning unit of the lungs. This is where you actually do your gas exchange, meaning you're dropping off your oxygen so it can actually be put into the bloodstream, and you're picking up your carbon dioxide from the bloodstream, and it's traveling to the alveoli to be exhaled out of the body. In order to accommodate this gas exchange, we see that the alveoli needs to have a very thin layer of water across its opening. The problem with this is that water has a natural cohesion property, meaning that it likes to stick to each other. And as it sticks to each other, it basically draws the walls of the alveoli closer, almost like it's trying to collapse it. The best example I can try to give you, if you want to try to visualize this, is imagine taking just 2 sheets of regular printer paper and completely soaking them in water and then basically trying to separate them from each other. You're going to notice that the paper basically sticks so strongly together that as you start to pull them apart, they start to tear. So we see the same thing happening with the water and the alveoli. The alveoli are very fragile. Remember, they have a low blood pressure point, a high lymphatic drainage point, but they're very fragile. So that water has the ability to cause some damage. So how do we do this? Because we need the water for the gas exchange. Well, that's where we produce pulmonary surfactant. Pulmonary surfactant, which is produced by the alveoli cells itself, they are able to decrease the surface tension, so they loosen the relationship with the water molecules, therefore keeping the alveoli afloat and allowing gas exchange to occur. In fact, pulmonary surfactants are so important that that is one of the primary things that we have to worry about when a baby is born prematurely, because that is one of the last things that the baby's body will start producing for itself, because while it is inside of mom, it's obviously not needing to inhale and exhale for itself because it's getting all its gas exchange from mom's circulatory system. So if they see that the mother has to be induced early, usually what they'll see is that when the baby is born, the baby will get high doses of steroids as well as artificial surfactants. The steroids are meant to increase its production or its developmental rate of the lungs and initiate production of surfactant. And the artificial surfactant will keep the alveoli afloat in the meanwhile before it's time for the natural surfactant to kick in. Now, I do want to also point out some things when it comes to the ventilation of the air in the alveoli. First of all, as you're doing your homework or as you're perusing through the chapter, you might come across the term dead air, anatomical dead space, and physiological dead space. So dead air is basically any air that's traveling inside of your body that is not actively exchanging gases. So it's not actively in the lungs by the alveoli. So for instance, if you were to take a deep inhale for me, hopefully you can tell me that as you're inhaling, air will travel through your nares, in the nasal cavity, over to the pharynx. From the pharynx, it will go by my larynx. So we're visualizing our little epiglottis, the glottis for the opening, and from there it's going to go into the trachea, and from the trachea it's going to go into the bronchial tree. As the air is traveling, it is considered dead air because your body is not able to actively remove the oxygen out of it and put carbon dioxide inside of it. So dead air is an anatomic dead space. It is within the conducting division of airway pattern. It's on the way to the lungs, but it hasn't arrived there. Physiological dead space is when we take this anatomical dead space and we add it to any type of pathological alveolar dead space. So do you have any alveoli in your lungs that are not cooperating, that have died off, that can no longer do gas exchange? Well, if you take their surface area and add it to this dead space that the anatomical conducting division adds to it, you then create a physiological dead space. For many of us, if we have healthy lungs and we don't have any issues like COPD, our physiological dead space is just basically equal to our anatomic dead space because our alveoli are working perfectly. Now, a really good way that we can figure out exactly how much air is flowing in and out of the lungs, as well as to take a look at the strength of the muscles in generating the different pressure points, is by using spirometers. So on this PowerPoint here, we see a wide variety of different spirometers. On our left-hand side, we see one with a respiratory therapist, and as you can see, as the patient is inhaling and exhaling, she's recording the values on the computer. We also have, for instance, some handheld ones that do not require a computer setup. So for instance, on the right-hand side on top, you have a little dry air spirometer where you would just blow in by the blue tubing, and you can use the little gasket reading in front to see how much mLs of air are flowing in and out. If you've ever gone to the hospital, a lot of times you'll see the spirometer that's at the bottom right-hand corner, and the patient will basically have to blow through the tubing and levitate that little ball, and as it levitates the ball, the little yellow marker on the column will start to increase and decrease. And basically it's measuring how much air is flowing through your body. Because we now know that the lungs cannot inflate and deflate by themselves, that means that when we use our spirometer to measure our ventilation, not only are we analyzing the compliance and the condition of the lungs, but we're also taking a look at our muscle strength. Now in lab, I'm sure you'll do an activity where you'll get to play around with the spirometer and you're going to calculate some of your values. So I won't spend too much time on the spirometer aspect, but I do want to kind of show you some of the most important volumes that the technician will most likely look for. So I want to introduce you to these key terms just in case you may or may not cover them in lab. You'll at least have a nice basis for the spirometry. The first volume that I want you to know is what we call tidal volume. Tidal volume is basically the amount of air in one breath. So you would just have the patient come in and relax, and whenever they're kind of feeling a little comfortable, you would tell them to inhale into the spirometer, and that should usually be about 500 mL. Or you can measure how much air you normally exhale, and that would be about 500 mL. So a tidal volume is just how much air is involved in a regular inhale or how much air is involved in a regular exhale. So just a normal quiet breath. And like I said, it's about 500 mL. If you want to really get a nice look at how their diaphragm and their intercostal muscles are working together with the lung compliance, then we can go ahead and take a look at the inspiratory reserve volume and the expiratory reserve volume. So for the inspiratory and the expiratory reserve volumes, you start off the same way. You have your patient just inhale normal and exhale normal, just like they would normally do. And then for the inspiratory reserve volume, after that patient has a regular inhale, you would tell them to go ahead and forcefully inhale any additional air that they might be able to get into the body. So you would inhale, exhale, inhale, inhale deeper, 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 deeper. And as you're doing this with your maximum effort, you're engaging more and more muscles. For the expiratory reserve volume, it's the same concept, but now you're going to concentrate on excessively exhaling. So your patient would do a normal inhale, a normal exhale, and after that you would excessively try them to squeeze as much air possible as they can with maximum effort. I also want to point out to you that the lungs will never remain completely empty. There is always some residual volume that's left in there. This is usually what keeps the alveoli inflate. The spirometer is not able to measure residual volume, but by measuring other volume points, we can basically do some mathematical calculations to figure out how much is left behind. Two other volumes that I definitely want us to discuss is vital capacity and total lung capacity. Both of these volumes are done through calculations once the respiratory technician is able to do some exercises with the patient. Vital capacity is basically the total amount of air that can be inhaled and exhaled with maximum effort. So it is your deepest breath possible, your strongest breath possible. It's a forceful inhale followed by a forceful exhale, and it's a fantastic indication of the strength of your thoracic muscles and the compliance of your lungs. Your total lung capacity on average is going to be about 6 liters or 6,000 mL, and this is just basically how much air the lungs can hold on to. Now, as you can imagine, you've noticed that I didn't really put a lot of volumes for us to memorize. I discussed the tidal volume at 500 mL and the total lung volume at 6 liters or 6,000 mL. And part of that is because the volumes will start to fluctuate depending on many things. One of them is obviously something as body size. The larger you are, the larger the lungs are, the more air you're able to hold on to and exchange. Also, what we see happening is things like physical shape. If a patient comes in and they exercise consistently, what we see is that their respiratory muscles have a higher amount of strength. The lungs tend to be a little bit more pliant and flexible. Also age, unfortunately, as we age, the natural process is that lung compliance does start to decrease and our muscles do go through some atrophy and start to weaken a bit. So there are different factors that will come into play that can alter your volumes. This, of course, is all besides disease models, like if the patient has suffered from pneumonia or bronchitis or COPD. All of these can alter the numbers that you get with the spirometer. We can also see that when it comes to lung disorders, oftentimes they like to be categorized either as a restrictive or an obstructive disorder. A restrictive disorder means that you usually have a decrease in compliance. And that usually means that the patient has no problem getting air into its body. So the airflow isn't blocked, so there's nothing wrong with the nasal cavity, the larynx, the pharynx, the trachea, the bronchial tree. However, when it's time to actually get into the lungs and into the alveoli, usually we see that there are some clinical applications or some abnormalities. So in a restrictive disorder, something tends to be wrong within the lungs and the alveoli, which reduces your gas exchange. An obstructive disorder means that you have an obstruction in the airflow. So something is blocking air from getting into the lungs. So that might be that we have to look at the patient's nasal cavity. It's their pharynx, their larynx, their trachea, their bronchial tree. So we have to take a look at that conducting pathway because there tends to be an obstruction in there. Usually with an obstructive disorder, there's no issue with the lungs or the alveoli. So if we're able to get the air through the obstruction, they will have normal gas exchange. Just keep these two terms in mind because what we're going to see happening is as we continue through our lecture, we're going to take a look at different disease models. And then I want you to kind of figure out, hey, am I talking about a restrictive or an obstructive disorder? All right, now before we kind of continue on with the clinical application, I do want to kind of bring up a few things, which is that the air that's surrounding us, it's a composition of different gases. So it's nitrogen, oxygen, carbon dioxide, and a handful of other gases. And what we see happening here is that each gas has what we like to call its partial pressure. And based on its partial pressure, will determine if we are going to be inhaling or exhaling that gas. So what I mean with that is when you inhale both oxygen and carbon dioxide. So how do you explain that you only allow the oxygen to do the gas exchange and enter into the body, but not the carbon dioxide? Well, that goes back to the previous discussion that we had at the beginning of this lecture, which is that pressure always goes from high to low when it goes to airflow. So when you inhale oxygen and carbon dioxide as part of atmospheric air, we see that the partial pressure of oxygen is higher on the outside than it is on the inside of the body. So oxygen will enter in. On the other hand, partial pressure of carbon dioxide tends to be higher on the inside of our body than it is on the outside. So that is then why carbon dioxide has a much easier time flowing out of our body, which is why we're exhaling it. And this kind of makes sense because our body uses oxygen for things like aerobic respiration to generate ATP energy molecules. And as a side product, it produces carbon dioxide as a waste product, which it then has to expel out of the body. So in case some of you, when we were doing our previous discussion about atmospheric pressure and pulmonary pressure, in case some of you were thinking, but wait, how does it know oxygen from carbon dioxide from nitrogen? It's all based on partial pressure. So what does the individual gas contribute to the pressure point? Also, just a quick reminder that the air inside of the alveoli is going to be at a higher rate of humidification. It will also be a little bit warmer, and that will increase the amount of gas exchange that can occur excuse me, as air is making its way into our blood vessels for oxygen and out of our blood vessels, out of our airway pattern for carbon dioxide. The other thing I wanted to bring up that I'd mentioned to you before is the fact that in order for us to maximize our gas exchange, we do see that in addition to the gases going down their concentration gradient, we also see that there's Henry's law that we have to keep in mind. Henry's law basically says that the gas has to dissolve in water, and the amount of gas that is able to dissolve will be all dependent not only on its partial pressure, but also its solubility in water. And because that water aspect is so important, that is why we have that layer of water over our alveoli. And that is why the surfactant is so important, because it will keep the alveoli inflated and open while still providing access to that water layer so that we can maximize how much oxygen enters the body and how much carbon dioxide exits the body. On this slide, we see different examples of how lung disease can affect gas exchange within the body. So go ahead and take a look on the left-hand side, where you're going to see three scenarios of the alveoli. We have when it is under normal condition, quote unquote. So this is your healthy patient. The pink lines are the alveoli walls. So that is where your gas exchanges are going to start entering into the sacs, allowing for the oxygen to go into the body, carbon dioxide to come out. Now look at the panel that's in the middle, and that is what it looks like when a patient has pneumonia. Pneumonia can be caused by a bacterial or a viral infection, and it basically allows fluid and mucus to start accumulating in the alveoli. So remember how we were talking about how there is like a thin water layer that has to sit on top of the alveoli so that the gases can diffuse down their concentration gradient? Well, when a patient has pneumonia, what we see is that sitting on top of that water layer is a thick mucus layer. So it becomes very murky, very thick, very difficult for the gases to diffuse in and out. And as a result, what we see is it severely reduces the amount of gas exchange that a patient can do. In fact, go ahead and follow the red arrow by the pneumonia, and you can see the top box on the right-hand side. We have a comparison of the clear alveoli in A, and then the ones that are filled with mucus and fluid in B. Now, in the case of this happening, we see that the patient has no issue inhaling the air. However, it has a problem with the exchange of the air, so there's something wrong with the lungs and the alveoli. So therefore, would you consider pneumonia to be a restrictive or an obstructive disorder? Hopefully, we all went with restrictive. Because once again, restrictive means that there's something happening at the lung and the alveoli level, something that will severely hinder the compliance or gas exchange. Your third disease model, or I should say your third scenario of the alveoli, is in the circle labeled C, all the way at the bottom. This is when the patient has emphysema. Emphysema usually means that there's a breakdown in the alveoli walls, and as a result, we see that there's less surface area for gas exchange to occur. In fact, go ahead and follow the red arrow and take a look at the bottom picture on your right-hand side, and you can see the comparison of the surface area when it's quote-unquote normal versus when emphysema occurs. Notice how the alveoli has no walls on the inside. No walls means less area for gas exchange. Thereby, you also have a case where the patient is not getting enough oxygen into the body and not releasing effectively its carbon dioxide load. So, would you go ahead and classify emphysema as a restrictive or an obstructive disorder? Now, I feel like I can hear you saying restrictive because once again, the issue seems to lie with the alveoli and the lungs, and you would be correct in that. But it turns out that emphysema is going to try to trick us because as the patient suffers from emphysema, we see that they start to lose the surface area on the alveoli, which is a restrictive disorder, but that eventually will lead to a change in pressure differences, which will allow the bronchioles to start collapsing. And the second that the bronchioles start collapsing, it then becomes an obstructive disorder. So I always like to tell my students that it's very common to see emphysema listed as an obstructive disorder because of the fact that the bronchioles have a tendency to collapse. But if you're looking at the patient from the beginning stages of emphysema and you see that it's only affecting the alveoli levels, do not be surprised if they also mention it as a restrictive disorder. Now, oxygen and carbon dioxide transport. The next few slides are just going to be a few trinkles of information, not too much. We're not going to emphasize too much on them, so bear with me. But this slide basically says that when we look at how oxygen is being carried in the blood, we see that the majority of it, over 98.5% of it, is going to be bound to hemoglobin. That shouldn't be a surprise to anybody. We've discussed this before in our circulatory system. There is a little bit of oxygen that will be dissolved, that will just free float in the blood itself. And we also know that hemoglobin, your alpha and your beta chain, for each of the hemoglobin molecules, it's able to hold on to 4 oxygen molecules. When it comes to your carbon dioxide, we see that it has 3 options for its transport. The most common option is through carbonic acid. Then the second one is through an interaction with the hemoglobin itself. This will be a separate binding site than the oxygen, so it doesn't interrupt any of the surface area. And the third option is as dissolved gas. Now, you might notice on the PowerPoint that on top it says carbonic acid 90%, the hemoglobin, the carbonoamine hemoglobin 5%, dissolved gas 5%. And then at the bottom it repeats it again, the 3 options, but it changes the percentages. And that's only because it turns out that the ratios will change when we're doing our carbon dioxide exchange at the alveoles. Please don't worry about memorizing these percentages. I just want you to know that the most common way of transport for carbon dioxide is going to be through carbonic acid. And then I want you to take a look at the formula that's underneath that carbonic acid. And it tells you that the carbon dioxide that you naturally generate in your body as a waste product of aerobic respiration will start to interact with H2O, water molecules. And it will go ahead and create carbonic acid. And that carbonic acid has a tendency to further break down into bicarbonate and free-floating hydrogens. We're going to see this formula pop up again. So for now, when you look at it, I just want you to realize 2 things. 1, carbon dioxide will eventually become carbonic acid, which is going to be its main mode of transport in the body. And also, carbon dioxide is able to generate free-floating hydrogens. Okay? So just hold on to that thought for a little bit. We're going to revisit it down the line. Now, when it comes to our breathing rates, what we see is that the depth of the breaths that we take and how fast we take them is often going to be adjusted based on maintaining our level of pH, partial pressure of carbon dioxide, and partial pressure of oxygen. Okay, so those 3 things are going to be our controlling pattern of the rate and the depth of our breath. And the most common, the most powerful influencer will be the pH. All right, so let's talk about pH. And when I'm talking about pH, I'm talking about the pH of the cerebral spinal fluid. And as you guys might recall from, hopefully from 2085, or maybe from just a general chemistry class, when you calculate the pH of a solution, you're taking a look at how many hydrogens, H's, versus hydroxides that solution has. So on your PowerPoint, I wrote down pH is equal to hydrogen versus hydroxide. And the way it's going to go is that if the solution has equal amounts, then the solution is considered a neutral solution. And usually that pH is going to be around a 7. If we see that the hydrogens exceed the hydroxides, so H is more than OH, then we see that we created an acidic environment or an acidic solution. The pH will be below 7. And if we see that the hydroxides, the OH, are greater than the hydrogens, then we have an base or alkaline environment or solution that we are creating. So bear with me. I'm going to walk you through this, but keep in mind that whenever you talk about pH, it's all about hydrogens versus hydroxide. Now, from a homeostatic point, the pH in our cerebral spinal fluid, as well as the pH that's in our blood, is usually around 7.35. So we're pretty neutral. So our hydrogens equal our hydroxides. Now, remember where we get those hydrogens from? We get it from our carbon dioxide, right? So I have the formula written down for you again towards the top of the slide, and it's there to remind you that on a normal day, our carbon dioxide interacts with water, it gives us carbonic acid, and then it gives us bicarbonate and those free-floating hydrogens. And normally, you have equal amounts of hydrogens versus hydroxides, OH, which means that you are in pretty neutral territory. Now, what happens if we leave that neutral territory and we either become acidic or basic? Well, that's what the next two slides are going to discuss. So in the middle and the bottom of this slide, it says you can get respiratory acidosis if the pH falls below 7.35. So if the pH drops below 7, your cerebral spinal fluid and your blood can become acidic. And this is usually caused due to the fact that your body has more hydrogen molecules than it normally has. So hydrogen will start exceeding hydroxides. And this is usually seen when the patient is in hypercapnia. Hypercapnia means that they have abnormally high levels of CO2, and according to the formula above us, or above on the slide, it says that if you have CO2, you have free-floating hydrogens. So if your CO2 goes up, your hydrogens go up as well. So on your slide, it says hypercapnia is caused by high levels of CO2. CO2, carbon dioxide, can easily cross the blood-brain barrier, and it will start reacting with water and releasing hydrogens. And all this extra hydrogen is what's going to cause the concentration of H to exceed that of OH. So now you are in respiratory acidosis. So the question then is, how can we adjust our respiratory rate to get rid of this imbalance and go back to a neutral territory? Well, if your patient has high amounts of CO2, then what we need to do is we need to lower that amount. And the best way to do that is to start blowing off CO2. So we're going to notice that our patients will start hyperventilating. So they will start exhaling at a higher rate, at an accelerated rate, and as they're blowing off the CO2, what we see happening is that the formula starts to reverse itself, and your body will start using all those extra hydrogen molecules to generate carbonic acid, which in turn will generate CO2 and water. And that CO2 is what's being blown off and hyperventilated. So to do a little review, if your patient is in acidosis, that means that you have high levels of CO2, hypercapnia, and if you have high levels of hypercapnia, you have high levels of hydrogen. So the way you're going to solve this is by causing hyperventilation. Your patient is going to start excessively blowing off carbon dioxide, and as you rid the body of carbon dioxide, you rid it of the extra hydrogens, and eventually you'll go back to the balance of H equals OH, which will line up right around with our pH of 7, which is what we like for homeostatic purposes. Now, what about if we do the opposite? This would be respiratory alkalosis. Respiratory alkalosis says that our pH is above 7.45, so we become more basic, more alkaline, and this is because our hydroxide ions, or OH, are exceeding our hydrogen ions. This is usually caused by hypocapnia. This is when your patient has low levels of CO2. And according to our formula, if we have low levels of CO2, that means we're also not generating as many hydrogens as we normally would. hence the case of being more basic. So in this case, we want to preserve as much carbon dioxide that we have in our body. So we're going to start hypoventilating, which means that the patient will take a quick, short exhale followed by a regular inhale. And the hypoventilation is all meant to increase the amount of CO2 that the patient has inside of their body, allowing for more hydrogen ions to accumulate to reset the pH back to neutral. So if you do alkalosis, that means your pH goes up. That's because you have hypocapnia, low levels of CO2, which means low levels of hydrogen. So the way that the breathing is going to adjust itself is to try to reserve or save as much CO2 as possible. So the patient is going to be hypoventilating, very short, quick exhales. Now, at the bottom of the PowerPoint, we see Sheldon blowing in and out of a paper bag, and that's because I wanted us to kind of discuss how this whole scenario relates to when someone is having, for instance, an anxiety attack or a panic attack, and they start excessively hyperventilating. And one of the things that we see is that oftentimes someone will say, go get a paper bag, and you see them inhaling and exhaling out of the paper bag. So how does this all fit into our scenario? Well, first of all, a panic attack or an anxiety attack is not related to alkalosis or acidosis, okay? This is going to be a whole different neurological and psychological effect that's causing our breathing rates to be affected. But what we do see is that if you start manipulating your exhaling pattern and you start hyperventilating, then you're excessively losing carbon dioxide. You're releasing more CO2 than your body is used to. And as that CO2 is being released at an excessive rate, we can see that it can also cause our hydrogen molecules to go down, which will put us at risk of going into alkalosis. So you go and you get yourself a paper bag. And the point of the paper bag is twofold. One, it allows the patient to concentrate on the inflating and deflating of the bag, which seems to have a calming effect. But also, every carbon dioxide molecule that the patient is excessively pushing out of its body, they will automatically inhale back in. So make sure your bag doesn't have any holes. Okay, that was a dumb joke. But either way, something to think about. Now, the effects of carbon dioxide itself, usually we see that it has an indirect coupling with the pH, as we were kind of discussing before, because the carbon dioxide will control how much hydrogen ions you have floating around. We do see, though, that excessive levels of carbon dioxide can trigger an increase in ventilation rate, and this is all in an effort for our body to get rid of the CO2, because at the end of the day, it still sees it as a waste product. When it comes to oxygen, on the other hand, we see that usually it has very little effect. Your body is actually pretty good at maintaining its oxygen levels. However, we do run into a case where you can have a chronic hypoxemia, which means that on a long-term basis, your O2 saturation falls below homeostatic rates. That usually can either be caused by different disease models, or also it can depend on any type of injury that might occur to the patient, or even to some lifestyle changes, such as, for instance, going to a place that's at a higher altitude where the air is thinner for a longer period of time. Now, when you have your hypoxia, we see that it can fall into many different causes. So on this little PowerPoint right here, we have the four most common. We have the hypoxemic hypoxia, which usually means that your body is not able to meet its oxygen and carbon dioxide demands. And this could be through many different reasons. So as you can see, you can have your instance where you're at a higher altitude where the air is thinner, so you're not drawing in as much oxygen as you normally would with every breath. But it could also be a little bit more detrimental. So for instance, if the patient is drowning or going into respiratory arrest, or it has carbon monoxide poisoning or degenerative lung disease, anything that will prevent the gas exchanges from occurring could lead to this scenario. Ischemic hypoxia usually means that the blood is not able to adequately circulate, thereby not able to meet the oxygen and carbon dioxide gas demands. We usually see this in patients that are suffering or have recently suffered a heart attack. Part of why we want to get the heart beating back to quote-unquote normal is to maintain the circulation so that the body can do many things, including keep up with its oxygen and carbon dioxide demand. Anemic hypoxia means that your body's usually low on its hemoglobin concentration, or perhaps its red blood cell concentration, leading you to anemia, meaning that your oxygen cannot be transported effectively with the use of the hemoglobin molecules. And then histotoxic hypoxia is what we see in cases such as cyanide poisoning, where you have a metabolic poisoning that prohibits the body from absorbing the oxygen. I do want to mention something real quickly about carbon monoxide. One of the reasons why carbon monoxide is so deadly is because the carbon monoxide molecule will actually compete with the oxygen molecule for the same binding site on the hemoglobin. And the carbon monoxide has about 100 times higher affinity, so it has a higher pull towards that hemoglobin location, so it can bind quicker. So even though your patient is inhaling oxygen and carbon monoxide, because the carbon monoxide takes up all the hemoglobin spaces, the oxygen cannot effectively be transported in the body. And that's why that carbon monoxide poisoning can be so lethal. Some of the signs of hypoxia include blueness of the skin, and often what we see, that will be our first symptom, that cells are dying off, and you will get tissue necrosis, and obviously organs with the higher metabolic demands, such as our kidneys, our hearts, and our brains, are usually the first to be affected by this. You can also have the opposite, which is that you have oxygen excess. And this is usually known as oxygen toxicity. And this is usually seen when the patient inhales pure oxygen. So instead of atmospheric air, that's a combination of different gases, we see that the patient starts inhaling purified O2. And the problem with this is that at lengthier exposure of O2, it actually causes the body to generate lots of free radicals and hydrogen peroxide, which can basically start destroying your DNA structures. So we have a high rate of mutations that start to occur. In studies, it has shown that in addition to shutting down your proteins, it can also cause severe damage to the nervous system and can cause death in patients. Some of the studies come from the use of hyperbaric chambers. Back in the days, premature infants, also patients that would suffer from like burns, will be placed in a hyperbaric oxygen chamber, which would be filled with 100% oxygen. And what they started noticing, especially in the premature infants, is that the babies later on would start develop retinal damage and would report partial or complete blindness. And because of the research, they concluded that it was actually due to the fact of the high levels of oxygen that they were exposed to, generating the free radicals. This is one of the reasons why they no longer put pure oxygen in the hyperbaric chambers. They will slightly increase the oxygen content that we would normally inhale and exhale, because we see that a slight increase does speed up our immune system and our healing process, but they'll never give you pure oxygen. And that's the same thing that we see with the little animation on the screen, our little divers. The tanks are never filled with 100% oxygen. They will fill it with gases that are very similar to atmospheric content, which usually means more nitrogen than anything else. Now, as we get towards the end of our lecture, let's go ahead and take a look at some disease models. And we definitely have to talk about COPDs, which stands for chronic obstructive pulmonary disease. COPDs is a huge pharmaceutical market, and I don't think you can get through one cycle of watching TV at night without coming across a COPD commercial. This is for patients that on the long term will suffer with an obstructive disorder, meaning that their conductive pathway is being blocked by one way or another. So the first one to encounter is going to be asthma. This is the most common COPD. We've talked about asthma many times before. It's usually caused by high levels of histamine being released. Most of us get this through an allergic reaction, and as the histamine is released, it causes bronchial constriction. So as you can see on the little insert, the lumen of the bronchioles will tighten up, they will become smaller, making it harder for the patient to inhale air and have it travel over to the lungs. Oftentimes, the patient will carry around an inhaler that will have an antihistamine that can counteract this bronchial constriction. Another COPD is bronchitis. So itis means inflammation. So bronchitis is when you have inflammation within the bronchioles. And in chronic bronchitis, what we see happening is that the inflammation is causing the cilia, the small little hairs that wave on top of the pseudostratified epithelium. It's causing the cilia to stop moving, to become immobilized, and they start dying off. And as they die off, what we see happening is that our body will start enlarging our goblet cells and producing more and more mucus. The problem with this is that the mucus is not being able to travel up that mucociliary escalator. It's not being able to clear out of the bronchioles because the cilia is dead. There's nothing to move it. So the mucus just sits there surrounded by any type of cellular debris or pathogen that it has trapped, and it forms sputum. And the sputum is an alveolar growth media for bacteria. So the patient is consistently needing to seek treatment to clear the bronchioles and usually has an infection going on at all times. With chronic bronchitis, usually you have what they like to call the smoker's cough. It's that deep, nasty cough that you hear people do, and it's almost like you feel like the mucus is not moving anywhere. You can, that's usually the situation with chronic bronchitis. The patients, depending on their stage of this, will need to do daily treatments that will induce bronchial dilation, making it easier for the sputum to be released out of the bronchioles. Another COPD is the emphysema one that I was telling you about before. So here with emphysema, we know that our alveoli walls start breaking down, so there's less surface area, and as it has less surface area, it makes it harder for us to do gas exchange. Now, the fact that the walls break down, that makes it a restrictive disorder, but because that will eventually lead to the fact that the lungs will become more stiff, more fibrotic, meaning it will have more scar tissue, and they won't be as compliant or elastic. It will cause your air passages to collapse. So that is then, when it comes to that particular syndrome, it will be considered a COPD because the collapse of the air passage is an obstructive disorder. And we can't have a respiratory system without talking about lung cancer and smoking. Now, I won't harp on this too much because, unfortunately, not the reason, hold on, let me try to reword this properly. Just because you smoke doesn't mean you're going to get lung cancer. And just because you don't smoke doesn't mean you're not going to get lung cancer. Unfortunately, what we see is that the new cases of lung cancer, most of the patients have never smoked or have been exposed to secondhand smoke. So there doesn't always need to be a correlation. We do know that smoking tends to increase your chance of lung cancer because of the high levels of carcinogenics that you expose your lungs to anytime you are puffing on that cigarette or on that e-cigarette. Now, when it comes to lung cancer, there are three main categories. The most common one is the squamous cell carcinoma. This one starts out with the bronchial epithelium transitioning or transforming into stratified squamous epithelium. And the change in histology actually makes it harder for the lungs to function. And what we see happening is that scar tissue or the tough protein keratin will start replacing functional respiratory tissue. Adenocarcinoma is another type of lung cancer. This one starts within the mucus glands of the tissue. And then the least common but the most dangerous is what they call oat cell carcinoma or small cell carcinoma. It gets the name oat cell because it looks like little oatmeal kernels when it starts to develop. Small cell carcinoma is very dangerous because it metastasizes very quickly, meaning it tends to divide and spread from its original point. And the issue with cancer is that the more it metastasizes, the harder it is to treat. The nasty thing about lung cancer is a lot of patients won't realize they have lung cancer until it starts metastasizing, and usually one of the first symptoms is that they'll start coughing up blood. At that point, it makes it harder for the cancer to treat, and prognosis is particularly poor when it comes to lung cancer. But there are very aggressive treatment options out there, and more research is being done every day to try to combat this carcinoma. And on our last slide right here, I just want to show you a quick comparison of a healthy lung versus a smoker's lung with carcinoma. So on the healthy lungs, you see all that healthy, beautiful tissue, all that pink, full of elasticity, able to inflate and deflate. And then on the right-hand side, notice how the lung is smaller. It also has lots of black spots on it, which are indicative of the fact that it's full of keratin and scar tissue, so it's not as flexible. And it also has some hematomas and blood bursts going on, which is what you see on the side. And the end result, what we see is that the lung is not able to inflate and deflate, which will significantly compromise the gas exchange for the patient and obviously also its quality of life. All right, I'm sorry that I have to end the lecture with a picture like this. I guess I should have put maybe a happier picture. I'll work on that for the next presentation. All right, guys, let's continue our discussion on the respiratory system in our discussion sections. And let's also make sure that you send me any emails with your questions, comments, and concerns. And we are getting pretty close to taking our third exam, so I will talk to you soon.